set aside time for a business meeting tonight to talk about a subpoena that we thought we were going to need to issue. We asked for some information from the department almost a year and a half ago. Miraculously, it appeared today. So that negates the need for us to move forward with a subpoena on that particular issue. So we will not be having the business meeting that we originally had noticed and talked to everybody here on the committee, and I appreciate it. Good evening, everybody. I want to welcome you again to tonight's hearing entitled Oversight Hearing on Data Manipulation and Access to VA Healthcare, testimony from GAO, the IG, and from VA. And tonight we are going to address ongoing issues of systematic wait times, manipulation that occurs throughout the Veterans Health Administration and negatively impacts the veterans that we serve and the health care that they should be provided. VA wait times and scheduling issues have been the subject of numerous investigations by the committee for many years. We have many outstanding requests for information and have held hearings to address the problems within VA that have led to veterans waiting so long for needed care. The VA's Office of Inspector General has also repeatedly warned the VA about its substandard scheduling practices. From as early as 2005, in numerous reports, VA OIG has noted that medical facilities did not have effective electronic waiting list procedures. Their outpatient scheduling procedures needed improvement nationwide. Their data was often unreliable, and they overstated their success regarding patient wait times. In December of 2012, GAO found that VA's reported wait times remained unreliable. VHA's policy continued to be implemented inconsistently across VA. Schedulers, in fact, lacked proper training, and VHA's appointment scheduling system was outdated and inefficient. Despite these repeated warnings that have come from Congress, from the GAO, and even from VA's own investigative body, issues with patient wait times and scheduling remain a pervasive problem today. Last year, this committee requested that GAO conduct a separate investigation to confirm the extent of problems throughout the VHA regarding ongoing issues with patient wait times and consult delays. GAO will testify as to its findings here tonight. Recently, the committee received whistleblower complaints regarding the Phoenix VA health care system that explained how the facility was keeping numerous wait lists to give the impression that its wait times were much shorter than they actually were. One of the secret wait lists at the facility, sources found that as many as 40 patients may have died while they were awaiting care. After the committee was able to confirm these allegations, we made the issue public during our April 9th, 2014 hearing. At that hearing, I asked that the VA OIG look into those allegations which prompted its investigation. The interim results of that investigation were released on May 28th of 2014. In that report, the OIG substantiated a number of problems at the Phoenix VAMC, but also noted how it has opened or has planned to open investigations into 42 different VA medical facilities. The OIG found that at Phoenix, at least 1,700 patients who were waiting for a primary care appointment were not on the electronic wait list, meaning that these veterans may never receive such an appointment. Additionally, OIG found that the Phoenix leadership considerably underestimated new patient wait times, which it noted is its metric used to consider bonuses and salary increases for VA employees. VA OIG also stated that inappropriate scheduling practices like those found in Phoenix are systemic across the Veterans Health Administration. Finally, we were notified earlier last week that VA would provide the findings of its internal audit of appointment wait times by last Friday. VA provided us with those findings earlier this afternoon. Tonight, I look forward to hearing what VA has to say about its audit, how it plans to repair the damage it has caused by tampering with veterans' access to care. And with that, I now yield to the ranking member, Mr. Michaud, for any opening statement he may have.
Thank you very much, Mr. Chairman, for having this hearing this evening. There's nothing more important than the welfare of the men and women who have served this country with honor and distinction. I'm pleased our committee is continuing to move quickly and in a bipartisan manner to investigate the many serious shortcomings within the VA, especially those regarding access to health care. Now is the time for us to identify the problems so we can move forward and implement changes. That means working together on oversight and legislative solution. It also means having very frank conversation with veterans about their personal experiences, so we know how we can improve the system. Over the years, this committee has identified and helped fix many of the problems within the VA, but the VA is clearly facing a crisis that is now being addressed by the media and our increased oversight efforts. In this environment, it is especially important that we are fair in our oversight and measured in our responses. But above all, we must never fall short of doing what we need to ensure that veterans have access to the healthcare system that they've earned and deserve. It is important for us to work together to achieve the VA we envision. We must work together across the aisle and across the branches of government to fix these problems and ensure that the VA is caring for our veterans. When we work together, this committee works best. We know that the work that we must put forward, that we must ensure that the VA is receiving the necessary assistance and resources that they need to do what they have to. As I see it, there is critical questions that should be asked by this committee, questions that get to the root causes of the problems, questions related to the broad strategic changes needed at VA, changes in the leadership climate, encouragement with other agencies like DOD and HHS, increased utilization of the private sector, and long-term resource planning. We need to ask the hard question, what should the department look like in the future? These are not easy questions, nor do they have easy, simple answers. But today, more than ever, we must ask these questions and come up with these answers. I believe thoughtful, measured, sound policy is needed today more than ever. The answers need to be comprehensive and, when necessary, nuanced. For example, when holding leaders accountable, we need to not only focus on career senior executive members, but also the doctors and nurses who occupy administrative or executive leadership positions. As I mentioned earlier, HR 4399 closes a gap in the current package of legislation being considered by the House and the Senate. Mr. Chairman, I've always been proud of the bipartisan nature in which this committee has operated. My hope is that we'll continue that spirit, working together to help identify the problems and working towards a solution. No single individual has a monopoly on the answers, and no single individual or institution has all the answers. The work ahead of us will be hard, and it will require all of us to work together in that regard. The Veterans Service Organization, the department, this committee, the Senate, and the White House. And Mr. Chairman, I want to thank you once again for your robust advocacy for our veterans in holding all these hearings that we're having for the oversight. And it's my hope that when the committee asks for information from the Department of Veterans Affairs, that they provide that information in a timely manner, so we will not have to issue subpoenas to get the information that we need so we can do our oversight hearing. That's our responsibility, and we expect the department to help us do our oversight hearing as well. So with that, Mr. Chairman, I yield back to balance my time.
I thank you very much for your comments this evening. I would ask that all members would waive their opening statements. As customary in the committee, I would invite now the witnesses to please come to the witness table. And as you're coming forward, I will introduce you. Tonight we're going to hear from Dr. Deborah Draper, Director of Health Care for the Government Accountability Office, Mr. Philip Makovsky, Assistant Deputy Undersecretary for Health for Administrative Operations of the Department of Veterans Affairs, Richard Griffin, Acting Inspector General of the Department of Veterans Affairs. Mr. Griffin is accompanied by Ms. Linda Holliday, Assistant Inspector General for Audits and Evaluations for the Department of Veterans Affairs. I would ask the witnesses, if you would, to please stand, raise your right hand. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you very much. Please be seated. All of your complete written statements will be entered into the hearing record. Thank you for being here tonight, and Dr. Draper, you are now recognized for 5 minutes.
Chairman Miller, Ranking Member Michaud, and members of the committee, I appreciate the opportunity to be here today to discuss the ongoing difficulties that veterans are experiencing in obtaining needed medical care. In 2000 and 2001, we reported problems with wait times and medical appointment scheduling in VA medical facilities. In 2012, we again reported problems, including the unreliability of outpatient medical appointment wait times and the inconsistent implementation of VA scheduling policy, which impacted the timely delivery of care. We are currently conducting work examining VA's management of outpatient specialty care consults, a type of medical appointment, and have again identified problems that may hinder veterans' timely access to care. Across our body of work on access to VA health care, several common themes have emerged. These include weak and ambiguous policies and processes, which result in significant variation, confusion, and increased risk of undesirable practices at the local level. Software systems that do not facilitate good practices, inadequate training, unclear staffing needs and allocation priorities, and inadequate oversight, which relies largely on facility self-certification without independent verification, and the use of unreliable data for monitoring. My comments today focus mainly on preliminary observations from our ongoing work examining VA's management of specialty care consults. We found most of the 150 consults we reviewed were not managed in accordance with VA's timeliness guidelines. Specifically, we found 1 in 5 consult requests were not triaged within the 7-day guideline. We also found 38% of the consults were completed, but not within the 90-day guideline. 19% were completed within 90 days, but the provider failed to properly close out the consult in the electronic system. And the remaining 43% were closed without the veterans being seen. VA Medical Center officials told us that increased demand for services, patient no-shows, and canceled appointments are among factors that lead to delays and impact their ability to meet VA's 90-day consult completion guideline. During the course of our review, we also identified 1 consult in which the veteran experienced delays and died prior to obtaining needed care. I want to walk through the timeline of events for this particular case. In September 2013, the veteran was diagnosed with 2 aneurysms. In October, the medical center scheduled the veteran for surgery in November, but the surgery was subsequently canceled due to staffing issues. In December, the medical center approved non-VA care and referred the veteran to a local hospital for surgery. In late December, after the veteran followed up with the VA Medical Center, it was discovered that the non-VA provider had lost the veteran's information, which the medical center then resubmitted. In February 2014, the veteran died prior to the planned surgery at the non-VA provider. This particular case is insightful for a number of reasons, including that while non-VA care may expand capacity, there are also some potential pitfalls. For example, non-VA care requires prior approval, which may delay care. More coordination is needed between the VA Medical Center, the veteran, and the non-VA provider, and wait times for non-VA care are not tracked by VA. Our findings relative to our ongoing work include variation in how medical centers have implemented new business rules for specialty care consults, which limits the usefulness of the data for monitoring and overseeing consults system-wide, and an overall lack of oversight of the process, including no independent verification of medical centers' actions. As the demand for VA healthcare continues to escalate, it is imperative that VA addresses access to care problems. Since 2005, the number of patients served by VA has increased nearly 20%, and the number of annual outpatient medical appointments has increased approximately 45%. In light of this, the failure to address VA to address its access to care problems will considerably worsen an already untenable situation. Mr. Chairman, this concludes my opening remarks. I'm happy to answer any questions.
Thank you very much, Dr. Draper. Mr. Mikowski, you're now recognized for 5 minutes, and I understand you don't have prepared comments, but you are prepared to make some comments.
That is correct, sir.
You're recognized for 5 minutes.
Good evening, Chairman Miller, Ranking Member Michaud, and members of the committee. No veteran should have to wait unreasonable time for their care. They have earned this care. America's veterans deserve better. Secretary Shinseki and Acting Secretary Gibson have stated that we now know that within some of our healthcare facilities there are systemic and totally unacceptable lack of integrity. This is a breach of trust. It is irresponsible, it is indefensible, and it is unacceptable. I apologize to our veterans, their families, and their loved ones, members of Congress, veteran service organizations, our employees, and the American people. After this committee raised the issues in Phoenix at the VA healthcare system in mid-April, Secretary Shinseki directed a nationwide audit. I will be talking about that audit tonight and answering some detailed questions. This audit visited over 700 locations, involved over 400 of our national and field staff at the senior executive level, senior manager level, and frankly, line management level. We interviewed over 3,700 frontline staff members. We saw this as the opportunity for us to set a reset, to sweep away and establish a clear-eyed assessment of our actual performance, not our reported performance, and to establish a system-wide understanding of the change we needed to realize in our agency. We released our results this morning on all VA medical centers, all CBOCs, most mid and small CBOCs, and these results from this audit confirm the OIG interim report, our May 3rd initial release, and frankly, the GAO studies. I'm here to answer questions about this audit and other concerns. Our audit revealed a number of things. Number one, we have hard-working staff on the front line who work in a high-stress, complicated environment with, quite frankly, completely outdated technology. The most frequent challenges cited by our staff are, frankly, a lack of appointment slots into which to schedule veterans. They have a difficulty understanding our policies, and they rely on an antiquated system that requires numerous workarounds by well-intentioned staff. I have to admit that unfortunately we found that our staff had received instructions to enter a date other than the date a veteran wanted to be seen. We know there is an integrity issue here among some of our leaders. We can and will address this issue. I want to make a comment about reprisals against employees. Acting Secretary Gibson had mentioned this, that it is not tolerated in our system. We need our staff at all levels, but most importantly, at the point of care. We need them to tell us how to improve our system to be able to deliver care better for veterans, and they must feel safe to identify problems, and they must feel empowered to find solutions. Acting Secretary Gibson has announced immediate actions. We will expand and create new veteran satisfaction surveys for patient care. We will begin with veterans and their perspectives. We are holding senior leaders accountable. All of our senior leaders in the field over the next 30 days are expected to inspect their practices in their facilities and to be personally accountable for the integrity of those practices. We removed the 14-day scheduling goal from employee performance plans. We are increasing the transparency in the reporting of our data, and we will be releasing our access and timeliness data bi-monthly from here on out. Acting Secretary Gibson also announced an independent external audit of the integrity of our scheduling metrics. We're deploying a team to Phoenix to fix all aspects, not just their scheduling and access management practices. And we're formalizing a process for those high-performing sites in both quality, access, and integrity to be able to provide guidance and leadership to our staff and facilities that require support. We've directed staff to Phoenix to hire additional staff, to bring in temporary clinical staff, to bring in mobile medical units that are currently on the ground, to increase local contracts to include for primary care. And we are removing leadership where appropriate. We have suspended all SES performance awards for FY14 for VHA. And we are freezing hiring for VISN and VACO staff so that we may focus our HR hiring efforts on bringing on needed clinical, engineering, and administrative staff to the field. Secretary Gibson will travel to a series of VA facilities over the next few weeks to meet with veterans, their families, employees, and to identify obstacles to timely quality health care. Secretary Gibson has said that we must restore America's trust in VA healthcare system, and we must restore that one veteran at a time. Our dedicated workforce, over a third of whom are veterans, are engaged. Mr. Chairman, thank you for your dedication to and your care for our nation's veterans.
Mr. Griffin, you're recognized for 5 minutes.
Chairman Miller, Ranking Member Michaud, and members of the committee, thank you for the opportunity to testify tonight to discuss the interim results of the Office of Inspector General's work related to delays in care at the Phoenix healthcare system. I'm accompanied by Ms. Linda Halliday, Assistant Inspector General for Audits and Evaluation. The issue of manipulation of wait lists is not new to VA, and since 2005, the OIG has issued 18 reports that identified at both the national and local level deficiencies in scheduling, resulting in lengthy wait times and a negative impact on patient care. We are using our combined expertise in audit, healthcare inspections, and criminal investigators to conduct a comprehensive review requiring an in-depth examination of many sources of information, necessitating access to records and personnel both within and external to VA. We are charged with reviewing the merits of many allegations and determining whether sufficient factual evidence exists to hold VA or specific individuals accountable on the basis of criminal, civil, or administrative laws and regulations. Veterans who utilize the VA healthcare system deserve quality care and timely care. Therefore, it's necessary that information relied upon to make mission-critical management decisions regarding demand for vital healthcare services must be based on reliable and complete data throughout VA's healthcare networks. To date, we have ongoing or scheduled work at 69 VA medical facilities and have identified instances of manipulation of VA data that distort the legitimacy of reported waiting times. When sufficient credible evidence is identified supporting a potential violation of criminal law, we are coordinating our efforts with the Department of Justice. Our work to date has substantiated serious conditions at the Phoenix healthcare system. We identified about 1,400 veterans who did not have a primary care appointment but were appropriately listed on the Phoenix electronic wait list. However, we identified an additional 1,700 veterans who were waiting for a primary care appointment but were not on the electronic wait list. We reviewed a statistical sample of 226 Phoenix appointments for primary care in fiscal year 2013. VA national data, which was reported by Phoenix, showed these 226 veterans waited on average 24 days for their first primary care appointment, and only 43% waited more than 14 days. However, our review showed that those 226 veterans in our sample waited on average 115 days for their first primary care appointment, with approximately 84% waiting more than 14 days. We did not report the results of our ongoing clinical reviews in our interim report as to whether any delay in scheduling a primary care appointment resulted in a delay in diagnosis or treatment, particularly for those veterans who died awaiting care. The assessments needed to draw any conclusions require analysis of VA and non-VA medical records, death certificates, and autopsy results. We've made requests to appropriate state agencies and have subpoenas to obtain non-VA medical records. All of these records will require a detailed review by our clinical teams. While we make recommendations to the VA in our final report, we made 4 recommendations to the VA Secretary for immediate implementation to ensure veterans receive appropriate care. We will address the sufficiency of VA's implementation of these recommendations in our final report. Our recommendations include taking immediate action to review and provide appropriate health care to the 1,700 veterans identified on not listed on the waiting list at Phoenix, and to take the same action at all facilities in the VA system. Mr. Chairman, this concludes my statement, and Ms. Halliday and I would be pleased to answer any questions.
Thank you very much, Mr. Griffin, for your testimony. Members, we will all do a round of questions at 5 minutes apiece, and we will do a second round, I'm sure, after the first round. Dr. Draper, in your comments, you said that 43% of the consults you reviewed were closed without the veterans being seen. Can you give me an explanation as to why the care wasn't provided?
Yeah, there are various reasons. One is patient no-shows, canceled appointments, and this is canceled either by the patient or the medical center. And we also found instances of, some records we couldn't tell. We looked at it, and there was no documentation as to why the consults were closed.
Mr. Mikowski, how does VA schedule appointments? Is it through a telephone call to the veteran, or is it by a letter?
It is typically through a telephone call with the veteran. The veteran may call us. We may call the veteran. We will notify the veterans on a recall reminder process, which does involve a letter, sir.
That's interesting, because I've heard numerous veterans tell me that they receive letters telling them when their appointment will be, and not asking whether or not they can attend that particular appointment. So I'm a little confused.
Sir, I've heard that as well. That is not appropriate. That increases our rate of no-shows. It is not veteran-centric. We need to change that. We should be having a conversation with a veteran.
Griffin, one final question before I yield to the ranking member. Have you found evidence of criminal activity in your assessment?
We have found indications of some supervisors directing some of the methodologies to change the times. We have been in discussion with the Department of Justice concerning those, and whether or not, in the opinion of the Department of Justice, they rise to the level of criminal prosecution is still to be determined in most instances.
I appreciate you talking with the Department of Justice. The committee has written a letter to them also asking that they open an investigation. We haven't heard anything from them to date. Mr. Lamborn, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate the work you're doing on this issue. One of the areas that is going to have to get further review is in Colorado Springs, Colorado. And there are 3 anonymous whistleblowers who have come forward and said that there are problems with manipulating waiting times. And I've talked to the leadership in both Denver and Colorado Springs. They have told me personally that this is not going on, and I believe them, but at the same time, we have whistleblowers saying that it is going on. Mr. Metkovsky, how does the VA treat whistleblowers? And what I'm getting at is there is intimidation taking place. How do we change the culture from intimidation to where people are free to step forward?
Part of how we designed this audit was to have direct access to the front line from our senior staff. When our auditors went to the field, they met at the same time with union representation at the field and the facility management. Not 2 separate meetings, 1 meeting. We did not provide advance announcement of who we wanted to interview. We provided that when we showed up so that we could have a direct conversation. I will tell you, I have read through the open-ended comments of all of the responses that I could, and nothing saddened me more than an employee who says, I was trying to do it right, I know it is right, and I received instruction to do it wrong. That is just simply not tolerable. Retaliation against whistleblowers is also not tolerable. We cannot condone that. We require a leadership and cultural shift in our way of managing.
And I raised this a couple weeks ago at our last late night hearing, and that is, if you can't rely on the data, if you can't rely on the records, because secret waiting lists by their nature are meant to conceal the truth from someone who's doing a review, like yourselves. Is the alternative to go in and do a case-by-case analysis, talking to every single veteran who tried to get an appointment and doing this on a one-by-one, even if that takes hundreds or thousands of contacts? How do we get to the bottom of it when the records or the reports are not reliable?
I believe we have to begin with the end in mind. If what we want to do is to provide veterans with timely, quality health care, let's ask them, how are we doing? How's our care? How's our access? Is our access meeting your requirements? Is it not? If not, let's fix it. The thing that's terrible about this crisis is this isn't even an output measure, right? It's an activity measure. And what happens when we change that activity measure is we can't tell where we're not timely. If we can't tell where in no cases were we finding frontline staff who were delaying care by moving the appointment later in the calendar. They were changing the reference point. When that happens, we don't know where we're late. When we don't know where we're late, we can't identify where we need resources or to realign resources. And when we don't know that, our entire system of requesting for resources is thrown off.
And Mr. Metkovsky, I hope we've seen the final days and never again where bonuses or promotions are based on metrics that can be manipulated instead of, like you mentioned, and I've mentioned this before and others have also, outcomes like patient satisfaction or good care that can be documented, not metrics that can be manipulated.
I concur.
And do either of you other 2 folks want to comment on that issue? Mr. Griffin?
I think it comes down to accountability of the senior leadership out at these facilities. And once someone loses his job or gets criminally charged for doing this, it will no longer be a game, and that will be the shot heard around the system.
Thank you. I yield back.
Ms. Brown, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, thank you for having this hearing and here tonight. We all on this committee because we care about the veterans, and you can be sure the only reason why I'm on this committee is I care about the veterans, and I've been on this committee for 22 years.
2 of the visits that my veterans visit, number number 4, and number 3. 3 of the facilities, the Lions facility, the Philadelphia facility, and the Wilmington facility, are all in that further review category, and I request the same information that Mr. Denham did. I have for purpose of, I think, why all this started, and the secret list, so we say, as a simplistic question, is Vista not capable of scheduling 2 years out? And if we didn't have the metrics that Dr. Lynch sat here numerous times a couple of weeks ago and said, these metrics are forcing us to play these games, is that a possibility?
I think it is part of it. I think that they go hand in hand. But first of all, I think setting an unrealistic performance metric and tying rewards or incentives to the meeting, again, this isn't even an outcome measure, right? This is an activity measure. Tying rewards or incentives to the attainment of an activity was a mistake. Not understanding the capacity of our system when we set that was a mistake. There are reasons why we don't schedule 2 years in advance, quite frankly. You don't want to hold up the entire set of appointment slots with appointments that are so far out that they might end up getting missed. I mean, there are technical reasons why you wouldn't do that. But for the most part, this is a leadership and culture question. We have found in some of our networks where staff are using the same outmoded technology as other staff, using the same policy, and can schedule with integrity.
I bring that up because I think you kind of touched on it there. There's a balance there. And what is it? And I think it's going to go to my next question, and I think several people have brought it up. Standardized procedures and policies from Washington. I mean, you've seen it, the different visits, the wait time issues, and it goes to this question that I asked last time, and I, believe it or not, got a response this afternoon. I asked a question about a auditing feature that was turned off in the Phoenix region there, and got a response that it had been turned on nationally. Could any of those audit features been turned on, helped the IG in the process, and or internally in that region for them to avoid these situations?
Sure. I think the one thing that I would clear up is that audit, it's audit logging inside Vista that sort of records who edited what and captures those edits, was never turned on anywhere. The concern was that it would affect system performance and it would create a huge data storage requirement, so it was never turned on. That is now turned on across the board. That'll help us understand who edited what kind of appointment. So for instance, I think the one comment was made how you would cancel an appointment. We could see who did that, and if that occurred numerous times, we could marry that up and find that behavior. Who edited what kind of field at what time helps.
And I just want to make this statement because I'm sure, as Chairman just said, there were millions of dollars spent for that feature in the initial outroll of that system.
I would say the one thing that we're going to do different with this acquisition is that it's not going to be just a proposal. Part of what we're going to expect folks to give us is working software that is proven to integrate with our system.